All right, we support research at the Robert Wood Johnson Foundation and education on some of America's most pressing health issues, from improving access to equitable health care to supporting child nutrition and so much more. I'm in DC and available to help you with policy or research questions. You will receive information after this discussion about how to contact me. This morning, we're discussing the basics of Medicaid and its role in the health of communities. I'm pleased to introduce Heather Howard, Director of State Health and Value Strategies, which is located at Princeton University. SHVS, as it's called, is a program of the Robert Wood Johnson Foundation. It provides information and technical assistance to states seeking to leverage Medicaid to meet the unique needs of their state residents. Heather teaches courses on health policy at Princeton. She previously served as New Jersey's Commissioner of Health and Senior Services. Heather, I'll turn it over to you.
Thank you, Avenel, and thank you to the Robert Johnson Foundation for your support for independent research and your deep commitment to promoting health equity. We can go to the next slide. I'm really excited to be here today with everyone to talk about Medicaid. Medicaid plays a critical role in state healthcare systems and their economies, but it's often not as well understood as I think it should be for the critical program that it is. So I'm really delighted to spend a little time this morning to talk about it. And I want to cover some of the basics about how the program works and then touch on its role in providing coverage and access to care, how it addresses the needs of special populations, how Medicaid can drive value in the healthcare system, and then finally and critically, the role of Medicaid in promoting health equity. So if we can go to the next slide. Here are some key basics that I hope I will leave you with today. And as Avenel said, I look forward to your questions and also am available to talk after. My contact info is at the end of the slideshow if you ever want to reach out. So what are the key points? Probably the biggest one for you to take away today is that it's covering 1 in 5 Americans. And at the state level, in every state, it's the largest source of coverage. In every state, it's the largest health insurer. So when you're thinking about how you might want to drive value in your healthcare system, make sure you're thinking about the critical role Medicaid plays. It's also really a critical engine in state economies and a significant item in state budgets. As Avenel mentioned, I was the Commissioner of Health and Senior Services, so often thinking about budgets, it's nationally 1 out of every $6 spent in healthcare in the U.S. And it's the 3rd largest mandatory spending program in the federal budget. But in state budget, it's usually the largest or the 2nd largest. It depending on the state, it may vie with education as the largest budget item in state budget. So, for example, in fiscal year 2019, almost 29% of state budgets were spent on Medicaid. And something that's really important to remember is that not only is it a significant part of state budgets, but the state budgets operate differently than the federal budget. Every state is required to balance their budget annually, usually by their state constitution. So when we say it's the largest part of the state budget, that also means when states are struggling with grappling with balancing their budgets, Medicaid is usually at the center of those discussions. So now we can go to the next slide. Thank you. This is something that I drill home to my students, so I always want to start with this here, is the difference between Medicare and Medicaid. They both were created in the same law in 1965. So they have the same origin story, but very different policy pathways because of their design and who they reach. So Medicare is the federal program providing healthcare coverage for seniors and certain people under the age 65 with long-term disabilities. Medicaid, in contrast, is a joint federal state program that provides health coverage for lower income Americans and individuals with disabilities. So the key distinction is that Medicare largely is covering people over 65. Medicaid is covering low income Americans and people with disabilities. So those are the difference in who they're covering. But if we go to the next slide, there's also the difference in how the program is administered. So Medicare is that federal program. So if you're a senior in Alabama and a senior in New Jersey, the program is the same. But Medicaid is a joint federal state program. There are federal minimum rules that are set, but the states have flexibility to exceed those. So There are core benefits that have to be covered, but states, some of the services are optional, and the states can decide whether to cover them. So an example might be dental coverage. Not all states cover dental services for adults. That's a decision that states are making. The federal law gives states that discretion. Another area where states have discretion is states decide how much to pay for the services they provide. And remember, I just said that states have to balance their budgets every year. So these decisions are really set up against fairly significant fiscal constraints when states are deciding how much to pay a hospital or a physician. So you see significant variation across the country and how much providers get paid. Now, one thing that's set at the federal level is that federal matching rate. It's a joint federal state program. So but when a state spends $1 on Medicaid, states get a different amount of federal funding back. Let's use New Jersey again as another example. We are what's called a 50-50 state. So we get 50 cents from the federal government. Mississippi, the match rate is set based on the poverty level of the state. And so Mississippi has the highest federal match rate. Those match rates now, some of you may know, there was an extra 6% bump that was created last year in coronavirus relief. So New Jersey now gets 56%. For every dollar they spend. Mississippi, which is the highest, gets 84.5%. So that match rate varies across the country. And spending really varies. There's no one average amount spent on Medicaid enrollees because it really depends on how much the benefits that the state provides, those reimbursement rates. So it's really hard that, we often say if you've seen one state Medicaid program, you've seen one state Medicaid program because there's such significant variation. Now, if we can go to the next slide. This is a graphic representation of who's covered generally under Medicaid. Now, before the ACA, the Medicaid program going back to 1965 tended to cover children, pregnant women, and people with disabilities, and the elderly, low-income elderly. And so there was, I like this graphic representing sort of an umbrella covering people. Largely left off were adults without children and some parents. We get to the ACA in 2010, the ACA intended to create a national floor of coverage, saying that everyone up to 138% of the federal poverty level would be covered. So there wouldn't be that state level variation on who's covered. You might still have state level variation on exactly what benefits or how providers are paid, but you'd have uniformity. Of course, as many of you know, the Supreme Court in NFIB versus Sebelius made Medicaid expansion optional, so not all states have expanded Medicaid, which has led to what we now call the coverage gap, which is that no coverage gap in the middle. We have certain groups eligible because they were historically eligible for Medicaid. We have people above 100% of the federal poverty level eligible for subsidies in the marketplace. But in the states that didn't expand Medicaid, you have what's a literal coverage gap, meaning they have no access to health insurance. And this wasn't envisioned by the drafters of the ACA, but as a result of the Supreme Court making Medicaid optional, Medicaid expansion optional. So if we go to the next slide, I have now a state map, which shows you which states have expanded Medicaid and which states haven't. So the dark purple are the states that have expanded Medicaid, the light purple are the states that have not expanded Medicaid, and then Oklahoma and Missouri are the states that are expanding, but it goes into effect this summer on July 1. Both states are states that last year they had a public vote, a ballot initiative on whether to expand Medicaid, and the voters approved expansion of Medicaid, and then just set it up to start July 1 of this year, because of course there's ramp up time it needs for the state to prepare. So as of July 1, we'll have 12 remaining states that have not expanded Medicaid, and those are those light purple states. If we can go to the next slide, I'll talk a little bit about coverage for children. So almost 40% of our nation's children are covered by Medicaid. That's about 45 million kids. And Medicaid was created in 1965. The CHIP program was created in 1997 to cover kids at slightly higher eligibility levels. There was this recognition that we weren't doing a good enough job getting kids access to healthcare, and so Congress created the Children's Health Insurance Program to cover more kids at a higher eligibility level. So the good news is that now 45 million children are covered. The bad news is that still not all children in the country have access to coverage. So that's kids coverage. Medicaid also covers nearly half of all childbirths in the U.S. So with the new focus on maternal mortality crisis, Medicaid is in really, really well positioned to play a critical role in addressing that crisis because it's already covering nearly half births. So for example, in New Jersey, when I was Commissioner of Health and Senior Services, and we were thinking about how to improve maternal and child health, we had a really important lever through the Medicaid program, because it was paying for childbirth in about half the cases. Medicaid also actually funds, a lot of people don't know this, school-based health services. So in a school where the children being served by the school are enrolled in Medicaid, Medicaid may be reimbursing for the health services being provided. So maybe reimbursing the time of the nurse that's in the school, maybe paying for those vision and hearing screenings that are happening at the school. That's Medicaid. And that's money that money we trace back to federal money coming in to match state money being spent. So yet another example of the critical role that Medicaid is playing in our healthcare systems and covering important populations. If we can go to the next slide. So we talked about kids and childbirth. Medicaid also is covering other special populations, and particularly the elderly and disabled adults. And those are people who are relying on community-based or institutional long-term care services, such as nursing homes. Now, those populations are actually only a small percentage of the people in Medicaid. So about 6% of an average state Medicaid population are the elderly and disabled. But because their costs are quite expensive, nursing homes, we know, can cost up to $90,000 a year, that population is consuming a disproportionate share of Medicaid resources. So you have sort of an interesting balancing question. Kids make up the largest percentage of enrollees in a Medicaid program, but the elderly and disabled, because kids tend to be healthy, their costs are a smaller percentage, whereas the elderly and disabled are consuming a disproportionate share of those resources, about 40%. Another thing that's interesting, when we look back to the design of the Medicaid program in 1965, Medicaid is required to cover institutional care, meaning nursing home services, but those community-based services that help people age in the community, age in their home, are not mandatory services under Medicaid. So they're not required. And so states cover them at different rates depending on how states have chosen to cover those home and community-based services. And this may be an area you want to explore in the question and answer, but an example of those community-based services might be a home healthcare nurse who visits somebody in their home for a couple hours a day. And ironically, what we found, and RWJF's research has shown this, is that those home and community-based services are actually cheaper to provide and keep somebody in their home, where research has shown where people would rather be. They'd rather be in their home, in the community. But Medicaid, the design of Medicaid favors these long-term care services because nursing home services are what we call a mandatory benefit. So this is something that I know as congressional staff you're grappling with in the rescue plan, as you think about infrastructure. What is the role of long-term care services? How much should Medicaid focus on institutional care like nursing homes versus supporting the elderly and the disabled in their community, in their home? So I'd love to get into more of that if you have questions about that. Medicaid is also the number one payer for mental health and substance use disorders services nationally. So as you can imagine, Medicaid is a critical lever in addressing the most pressing behavioral health needs. That includes, of course, the opioid crisis. That also includes deaths of despair. That colleagues of mine at Princeton have coined that term, deaths of despair, as we've seen an increase in opioid, substance use, and suicide deaths over the last 10 years. So Medicaid is positioned to play a really important role in addressing those healthcare crises. If we can go to the next slide. Medicaid's also focused now on buying value and shifting to thinking about how do we get more value for every dollar being spent. 40 out of the 50 states now are contracting with insurance companies to pay for and deliver some or all of Medicaid services. What does that mean? That usually means managed care. And in states that can mean nonprofit or for-profit managed care companies. That varies by state. As states contract with, some states like Tennessee have contracts with three managed care companies that provide coverage to Medicaid enrollees in the state. Other states may have more than 10 contracts with managed care companies. And states are seeing those managed care contracts as leverage to pay for value rather than volume. And I'm sure you've heard talk about this. Volume is the traditional fee-for-service method of covering healthcare services and paying doctors and healthcare providers for every service performed. For example, we're going to reimburse for every X-ray that's provided. And instead, states have been saying, that's not efficient and doesn't lead to the best outcomes. How can we drive more value as we manage these costs and get more, and produce more quality outcomes? So they're doing that through managed care and through these contracts with managed care companies, where a managed care company will receive what is called a monthly payment, a per member per month is maybe a term you'll hear, to cover a patient, and then they'll have to manage their costs. And if it's a patient with chronic healthcare needs, the theory and what I've seen really in practice is that then the provider practices are incentivized to manage that patient's care rather than just thinking about episodic. We'll do an X-ray for here. It'll be here. We have a patient who is living with diabetes. How do we help them manage their diabetes? Well, maybe because we get a fixed amount of money to pay for that patient's care every month, maybe we'll have enough money, given how many patients we have in our practice, to hire a dietitian on staff who can help us manage that patient who's living with diabetes, manage that patient's care, and help them manage their diabetes so that it doesn't progress to late stage diabetes and cause all kinds of health complications. And by moving to value, states are directing the money in a way that can support these kind of innovations in the delivery of care and really support patients being able to achieve their own goals and needs by having better access to a suite of services rather than focusing on sick care. So this focus on value is nascent in some states and more mature in other states. But I'm excited to see that it's really happening across the country, and something we can get into in the question and answer if you're interested in hearing more about it. Let's go to the next slide. This is the final slide, but the most important slide, which is really the role that Medicaid plays in health equity, which has been a significant focus for the foundation, and I know for many of you on the Hill. A reminder that more than half of that, it's more than 70 million Americans are enrolled in Medicaid, and more than half of them identify as being in communities of color, Black, Latino, Asian American, Pacific Islander, or Indigenous. So Medicaid is poised to serve these communities and is already providing them access to healthcare services, and can play an important role in lifting up health equity and giving everyone the opportunity to succeed and to be as healthy as they can be. Let me give you a couple examples. As we've seen, and Avenel mentioned at the top, we know tragically that COVID-19, the pandemic, is disproportionately affecting communities of color. They have higher overall rates of infection, hospitalization, and death. And Medicaid coverage is an important safety net for people who may be infected. We also know now that through Congress, Medicaid is now covering testing and the vaccine at no cost sharing for beneficiaries. So Medicaid's playing a critical role in helping to treat people and then hopefully immunize people for COVID with the COVID vaccine. We also know, I mentioned earlier, that we are facing a maternal mortality crisis in this country, and particularly African American women dying at higher rates. And we know there's been a lot of legislation and a lot of interest on the Hill. Medicaid is a key lever to be promoting maternal health. I was really excited to see that Congress in the American Rescue Plan provided states the option to provide coverage for women postpartum from 60 days to 1 year after birth. Currently, Medicaid now only covers women up to 60 days after the delivery. And Congress recognized that, unfortunately, many of the maternal deaths that we're talking about actually happen between 60 days and 1 year after delivery. So Congress gave states the option to extend health insurance coverage up to a year after. And we can talk about that in the Q&A, but that's been important. And several states have already started to explore that option. But that's the good news, that Congress is giving states this option to expand. The bad news, though, of course, the unfinished business is that nearly 60% of those in that coverage gap in the 12 states that have not yet extended Medicaid are people of color. So there are real equity issues there in terms of addressing that coverage gap and making sure that everyone has access to health insurance programs like Medicaid. I think that's my last slide. And Avenel, I'm going to turn it back to you. I know there were already some great questions from people about Medicaid.
Yeah, there sure are, Heather, but I just have to say that was really fantastic. Every single time I hear you present, I learn something new about Medicaid. So thank you for that. So we're now going to take questions. To ask a question, click the raise my hand button at the bottom of your screen. For those who are joining by phone, select *9 and we will call on you in the same way. Our first few questions were submitted in advance. The first one, Heather, that came through is, can you briefly, you've already talked about this a little bit, but can you briefly highlight how the American Rescue Plan impacts the Medicaid program?
It's a game changer in many ways. I'm so glad you're asking that. Let me highlight just a couple key provisions. One, there's an enhanced incentive for the 12 remaining states to expand Medicaid. In essence, for 2 years, it's a 5% bump in that FMAP, that federal Medicaid match, for the states that have not expanded Medicaid, on a 5% increase in their overall Medicaid spending. So we know that under the Affordable Care Act, states that expand Medicaid now will get 90% of those new costs covered, but this is an additional 5% increase in the Medicaid spending that the states have, not on their expansion, but on their overall Medicaid funding. So that's a significant incentive for the states that have not expanded. There's also a 10% increase in the Medicaid match for home and community-based services, because we learned it brought even more to the fore the importance of helping people age in their homes. But as I mentioned, Medicaid has this bias towards nursing homes because of the way the program is designed. So this 10% increase in funding for home and community-based services will allow states to basically really bolster the support for people who want to age in home, those home health services that I was talking about, and other services that help people stay in their homes. So that's really important. That's a 1 year 10% increase. There's that provision to encourage states to expand coverage postpartum for women up to a year. There's also funding for crisis intervention services so that states can help people avoid hospitalization and incarceration, people who are having behavioral health crises. And there's support for, as I mentioned, for COVID testing and treatment. Those are just some of the provisions, and I really do think those are game changers.
Thank you, Heather. And I know this is also a topic of interest for many in Congress right now. So could you touch on Medicaid and how it works in the U.S. territories and explain the funding cliff that those territories are facing?
So, yeah, I mean, as if everything we've discussed so far hasn't been complicated enough, Medicaid in the territories is different, Avenel, which I think if you're a health staffer on the Hill, let's just throw another complication in. But Medicaid in the territories is different. It's not an entitlement like it is in the states, where, as I mentioned, Mississippi, for every dollar they spend, they're now getting 85% reimbursement from the federal government for every dollar they spend. In the territories, it's actually a fixed allotment, a block grant that goes to the territories. And sadly, what we've seen is that it has never been enough to fund the cost. And so Congress has had to step in every couple of years and provide additional funding, because it's not been this entitlement funding, it's been this set allotment. And so, for example, that's meant that Puerto Rico, after Hurricane Maria, didn't have enough funding to meet the healthcare needs of its residents. And so Congress has been stepping in to help fill that gap. And the last time they did that was in 2019, where they provided additional funding to the Medicaid agencies in the territories. But that extra money runs out this September. So that's that fiscal cliff you're talking about. And so Congress is going to have to step in again to fill that, to make sure that the territories are able to meet the needs of their residents. And there are real equity issues here, real challenges in meeting the needs of these communities in the territories. And so this, I'm glad to hear that somebody is asking about this, that hopefully means it's in the mind of policymakers, is what's going to happen when that funding goes away.
Ah, that's great. And just to remind our audience, if you'd like to ask a question, you can click the Raise My Hand button at the bottom of your screen. For those who are joining by phone, select *9 and we'll call on you in the same way. All right, and our next question, Heather. So you touched on this again during your presentation, and it was just a little bit of a teaser. So we want to know a little bit more about what you think here. As we're hearing about Medicaid funding home and community-based services and that emphasis, can you explain how exactly that works and how it's playing out in the states?
So again, as I mentioned, going back to 1965, when Medicaid was created, healthcare looked very different, and the needs of the elderly looked different. I mean, I mentioned earlier that federal law requires certain services the states can go beyond. I mean, it's amazing to think back, but in 1965, Medicaid wasn't even required, states weren't even required to cover prescription drug services. And we know that Medicare didn't cover prescription drug services until Part D was created. Also in 1965, how we thought about care for the elderly and disabled was very different. So Medicaid, states were required to cover nursing home care, that institutional care, but not home and community-based services. Now, over time, we've learned that people can age in the communities, and that people want to age in their communities. And our communities are stronger for it, of course, as people age at home. But Medicaid, it's been hard for Medicaid to keep up because of this, what we call this institutional bias, that states have to cover nursing homes, but they don't have to cover home and community-based services. Now, states, of course, want to cover them. I did when I was Commissioner of Health and Senior Services, but you're grappling with budget constraints. And so you're always thinking about what we call balancing your long-term care budget. And in New Jersey, we were trying to get to a point where we were covering more home and community-based services than institutional services, because people want to be there. And that's why this 10% bump is so important, because it means states are going to be able to invest in those home and community-based services. And let me talk a little bit more about, so I mentioned that might mean a home care nurse who visits a patient and makes sure that they're taking their medication, that they may take their vital signs, see how they're doing. Another example of a home and community-based services might be what's called adult medical daycare, where somebody is living at home, but they go for a couple hours every day to an adult medical daycare center where they get access to group services, they get socialization. Nurses may check on them there actually and help them with their medication. And also you get some respite for the family caregiver who's unpaid and who's caring for somebody in their home, but you're getting the socialization and maybe access to some healthcare services at an adult medical daycare center, and you're getting some respite for the home. Often we know that so much of caregiving is unpaid by family members. So This 10% is going to allow states to invest in what states may be able to increase reimbursement rates for the home healthcare nurse who's coming home. We know that too often those providers are underpaid. There's high turnover in those industries, and so they may be able to pay more. They may be able to create more of these adult medical daycare options for people to be able to get out of their home and to go for socialization and other services. They may be able to, for example, even it sounds simple, but it's so important, building ramps to houses so that people who are in wheelchairs will be able to go outside of their home, being able to retrofit a bathroom in somebody's home. That one-time cost may be the difference between somebody being able to stay in their home or having to go into a nursing home. So this 10% gives states the money to be able to invest in the 1 year. Now, states will probably be coming back next year, and they're going to say there's always going to be those fiscal pressures at the state level because they have to balance their budgets. But at least for this 1 year period now, they're going to be able to invest. And I think the pandemic has just brought home how much people want to be in their homes and not in institutional settings. So it's going to be able to give states time to sort of re-envision what does long-term care look like. And for many people, it's not a nursing home. Nursing homes are an option, an important option for some people, and it's really the only option for certain people. But for many people, staying in their home or a group home, it might be a group home. So states may be able to use the money to buy a ranch house in a neighborhood, spend that money to retrofit the bathrooms and the doorways, and that one-time investment now becomes a group home for people with disabilities to be able to live in going forward.
Yeah, I can't help think about how transformational this can be for patients. So you think about the baby boomer generation and the increased rate in Alzheimer's and the ability to be able to keep those with dementia in their own home where they're recognized, the space that they're in can really mean a world of difference, not just for that patient, but for the family. So appreciate you going into that detail.
That's right. And that focus on the families, that's also adults with developmental disabilities who in the past would have been in an institution, but now can be in the community, living in a group home and maybe even working in the community because of those investments.
Great. All right, we have a question coming in from Jean Sumner. Jean, can you please unmute yourself to ask your question live?
I'm sorry, I'm fascinated by the discussion, but I hit the hand thing by mistake, so I don't have a question. It's a great discussion, though, so thank you.
No worries, Jean. Thank you for listening. So Heather, I'll move to another question that we have, which is, and you touched on this again, and I know this is another area where there has been a lot of congressional attention and surely has just been made even worse during this pandemic is opioid use and substance use disorders and the role that Medicaid plays in those services. And you touched a little bit on this in your presentation, but would love to get some more of your thoughts about how that works again for the patient and what more maybe can be done there.
You're right. I mean, I really am afraid that we aren't talking enough about the opioid crisis because of the pandemic, and that as we slowly come out of the pandemic, we need to turn our attention back to the crisis, which has not abated, right? And we know that isolation and lack of access to healthcare services may have even exacerbated the opioid crisis. So, as I mentioned, Medicaid is the number one payer for behavioral health services, and this is particularly true in expansion states where a lot of adults are now eligible for Medicaid and are now getting access to opioid treatment services. So that could mean inpatient treatment services or it can mean outpatient treatment services. It could be counseling. It could be Medicaid assisted treatment that's now covered by Medicaid. And we've seen states be really creative during the pandemic. States have been using telehealth services. They've reduced barriers to telehealth services in Medicaid so that people can have access to either group therapy or they can get medication. They can get access to Medicaid assisted treatment. They'll do people are using even phone-based services, and then they can when they need go in and get a prescription. So it's really states have been, it's residential treatment but it's also outpatient treatment services that states have been able to expand access to. And as people have become more comfortable going back to healthcare services, we've really seen people returning to those services.
Yeah, that's great. And you also touched on this in your presentation, but I'd love to spend just we don't have much more time, but just a few minutes on the maternal mortality crisis. Half of all births, that's a lot of births covered by Medicaid, and the potential there is really huge for helping to abate this crisis. Can you talk a little bit more about what states are doing that's innovative in this space and how Congress has stepped in to help?
So this has been a real focus in New Jersey for a number of years. You know, as you mentioned, nearly half of all births, that Medicaid is the payer. You need to be thinking about what role it's playing. When I was Commissioner of Health, we realized we had too high a C-section rate. And so we said, Medicaid said Medicaid is going to stop paying for elective C-sections before 39 weeks. And so we dramatically reduced the C-section rate because we were a payer. That was one example of a lever. What's happening now is states are saying, well, maybe we ought to be covering doula services, for example. Doulas are non-medical support services for pregnant people during delivery. And so Medicaid, New Jersey and a handful of other states are saying, how can Medicaid pay for support services for the pregnant person during delivery? And so they're paying for those services. That's an example where states can innovate. Or states now expanding coverage. We're saying women's healthcare needs don't end 60 days after delivery. We're seeing those deaths extending up to a year. So we need to make sure women have coverage, have a source of care. Too often, a woman delivers a baby and the attention turns to the baby and the women's healthcare needs are ignored. So let's extend up to a year. The problem was, before this recent change in Congress, states had to submit a waiver to the federal government to cover to provide coverage to women up to 1 year postpartum. So the waiver process can be lengthy. It can take over a year. It's a lot of work for the states. So states, it was very hard for states to do it given all they were dealing with. So what Congress did, I mean, this sounds like a wonky detail, but it's really important. Congress now has given the states an option to do this coverage through what's called a state plan amendment. Which again, sounds wonky, but it means they don't have to do a waiver, which was really onerous. So they've made it much easier for states to do this. And I think, so that option becomes an option a year from next spring. I think you're going to see a bunch of states come in and provide women that coverage up to a year. So that was an example of the federal government making it easier for states to do something they might want to do, but that it was hard for them to do. So it's about covering services like doulas. It's about expanding coverage postpartum, and it's about even using that payment lever, saying we're not going to pay for a C-section if it's not medically indicated. So those are all ways in which Medicaid can really play a role in addressing that mortality crisis.
Yeah. Thank you, Heather. Thank you for giving us some more detail there. Those are really some important points to take home. So we're coming up on the end of our session here. So I just want to thank you so much, Heather, for all of the knowledge you've dropped today. It's much appreciated. And I want to thank everybody else for participating today. I appreciate you giving us your time, and I really do hope that this was helpful. We're going to send everyone who's participated a recording of this webinar with links to resources and information on how to contact me and Heather. A brief anonymous survey will also be sent to you about today's discussion, and we would really appreciate if you could complete it to help us plan for future events. Thank you so much for joining, and have a great day.